Imagine going to a doctor to cure, like, severe chronic pain. And the treatment they prescribe involves inserting a probe into your spine and intentionally cooking a nerve at 194 degrees Fahrenheit.
Yeah, it sounds completely wild when you put it like that.
Right. But today, we're doing a deep dive into this exact topic. We've got a massive stack of sources today. I mean, we're talking FDA safety communications, clinical guidelines, physical therapy protocols, even, the FAQ sections of aesthetic clinics.
There is a mountain of material here for sure.
And our mission for this deep dive is to answer one very specific controversial question that we get asked a lot. Can radiofrequency and laser treatments actually cause the hypersensitivity that they sometimes claim to cure?
It's a huge question. I mean, it affects millions of people. These high-energy devices are literally everywhere now. They're used for routine hair removal, chronic neck pain, and they're heavily marketed for tissue rejuvenation, right?
Oh, absolutely.
Yep.
The pitch is always the same. It's a quick, high-tech, super precise fix.
Exactly. But the human nervous system doesn't really react to these engineering tools in a clean, predictable way.
Yeah, when you actually dig into these clinical sources, the short answer to whether these devices cause hypersensitivity is just a resounding yes.
Yes, 100% yes. But what's fascinating here is the underlying biology of why that happens. It's incredibly complex.
Because it really depends on context, doesn't it?
Right. It depends entirely on whether the thermal energy is just, grazing the outer barrier of your body, or if a physician is actively weaponizing that energy to destroy tissue deep inside the spine.
So let's start at the surface. We can see this dynamic really clearly when we look at the most common application, laser hair removal.
Oh, yeah, that's a classic example.
Because it's incredibly common to read through patient forums where people are just panicking, like 24 hours after a session. They're convinced that the burning, tingling sensation means the laser permanently damaged their nerves.
Which is completely understandable. The brain is literally hardwired to interpret burning and tingling as a major nerve threat.
Right. Your body is sounding the alarm.
Exactly. But the clinical sources are definitive here, that temporary hypersensitivity is practically never true nerve damage. It's really just a normal, healthy, inflammatory response to thermal energy.
Okay, so let's unpack this a bit. Because the laser is designed to target melanin, right? The dark pigment inside the hair follicle.
You've got it. The light energy is absorbed by that pigment and instantly converted into heat. And that localized heat essentially creates a microburn to destroy the follicle so the hair can't grow back.
And because it's a burn, the body responds the way it always does to heat trauma.
Exactly.
It rushes blood to the area, creating swelling, redness, and, that stinging sunburn-like tenderness. It's an inflammatory cascade on the very surface of the skin.
Yeah, it's just physics and anatomy, really.
Yeah.
The wavelengths used in cosmetic hair removal simply cannot penetrate deeply enough into the tissue to strike major nerve trunks.
Because the major nerves are insulated much deeper down, right?
Yeah.
The localized heat just stays in the epidermis and the upper dermis.
Right. It's safe.
I was reading this and thinking, it's a lot like mowing the lawn and worrying you're going to slice through the city's underground water pipes.
That is a perfect analogy. You're just cutting the grass on the surface. The laser is targeting those shallow follicles far beyond the reach of the peripheral nervous system's main cables.
So when do things actually go wrong at this level?
Yeah.
Because the sources do mention complications.
Well, the complications really only spike when improper settings are used. Like if a technician treats someone with a fresh sunburn or uses a wavelength that's inappropriate for a darker skin tone.
Because then the melanin in the skin absorbs too much energy, right?
Exactly. But even in those severe clinical cases, the result is a superficial skin burn or maybe some pigmentation change. You are not severing nerves.
Okay, that makes sense. So that routine tingling should just fade completely as the superficial inflammation subsides over like 24 to 48 hours.
Precisely. It's temporary.
So if the body's pain receptors react that aggressively to a superficial, highly controlled microburn on the tough outer layer of the skin, the obvious question is, what happens when you apply these energy devices to highly delicate internal tissues?
This is where things get really intense. This brings us to a massive shift in the medical landscape over the last decade.
Right, the move toward treating mucosal tissues.
Yeah. Energy devices, specifically CO2 lasers, erbium lasers, and radiofrequency tools, are increasingly being used in procedures marketed as, quote-unquote, vaginal rejuvenation.
And here is the massive contradiction we found in the clinical guidelines. It's mind-blowing. Aesthetic clinics explicitly market these exact devices to treat vaginal dryness, tissue atrophy, and painful intercourse.
Yep. The pitch is that they'll restore tissue health and eliminate pain.
But then you look at the sources, and in 2018, the FDA issued a stark public warning about severe adverse events associated with these devices when they're used for cosmetic rejuvenation. How could they possibly cause the exact hypersensitivity they claim to cure?
Well, what's fascinating here is the mechanism they're relying on. It's called controlled thermal injury.
Controlled thermal injury.
Yeah.
That sounds like an oxymoron.
Right. The objective is to use the laser or the radio frequency waves to intentionally injure the vaginal mucosa.
Intentionally injure it.
Yes. The body registers this injury and attempts to heal the micro wounds by sending in fibroblasts.
And fibroblasts are like the biological builders in our connective tissue, right?
Exactly. When they're stimulated by trauma, they produce new collagen and elastin fibers. The theoretical goal is that this new collagen will thicken the tissue and improve moisture.
But relying on thermal injury to cure pain in a highly innervated, delicate mucosal area seems incredibly risky. I mean, mucosal tissue doesn't have the same dense, protective outer barrier that the skin on your leg does.
It doesn't. The margin for error is razor thin. It is a precarious balance between gently stimulating fibroblasts and creating a severe destructive burn.
And organizations like NICE, the National Institute for Health and Care Excellence, have flagged this heavily in the sources.
They absolutely have, because when that thermal energy penetrates too deeply, or if the tissue is just too fragile to begin with, the resulting hypersensitivity isn't a 24-hour tingle. It spirals into a chronic pain condition.
The case studies in these clinical overviews really illustrate exactly what that FDA warning was about. There was one specific case that stood out to me.
Oh, the 61-year-old patient.
Yes, a 61-year-old woman who initially went in with mild dyspareunia, so just mild pain during intercourse. She underwent 3 sessions of this laser therapy, and 10 months later, her condition hadn't improved at all. It had deteriorated into severe, unmanageable pain.
Her clinical exam is just a textbook example of the cascading failure of the nervous system when it's subjected to improper thermal trauma. She presented with severe vaginal dryness, burning, and itching.
And the physicians performed a Q-tip test, right? Which revealed intense vestibular inflammation. The entire region was just highly sensitized.
Highly sensitized. And her exam also showed severe pelvic floor hypertonus.
Meaning the thermal trauma caused her pelvic floor muscles to lock into a constant involuntary spasm.
Exactly. Her body experienced the laser as a severe physical threat, and the muscles clamped down in a permanent guarding mechanism. It created a localized chronic pain cycle that she couldn't just switch off.
It's like the nervous system fundamentally altered its baseline. It perceived ongoing danger long after the laser was actually turned off.
It did. And there was another case study in that same report, a 55-year-old woman with a similar baseline of just mild discomfort.
Right, and after 3 laser sessions, she experienced severe pain upon any insertion. The physical exam revealed that the body's attempt to heal the thermal injury had just gone completely wrong.
Yeah, instead of laying down supple, flexible collagen like the treatment promised, her body laid down rigid scar tissue.
She actually developed a crescent-shaped fibrous band inside the vaginal canal.
It created a partial stricture, physically narrowing the tissue.
Her body basically treated the laser like a severe burn and built a wall of inflexible scar tissue to protect itself.
Exactly. And look, while some observational clinic studies claim patients see symptom improvement, the NICE guidelines clearly state that long-term evidence is inadequate. They specifically warn of risks like vaginal burns, scarring, and chronic severe pain.
Because the anatomy of mucosal tissue means the nerve endings are dense and incredibly close to the surface.
Right. The risk of the inflammatory response misfiring and generating permanent hypersensitivity is severe.
Okay, so we've been talking about accidental skin irritation and the unpredictable risks of trying to, gently stimulate internal tissue. But what happens when the physician's explicit goal is to completely destroy a nerve using this exact same energy?
This moves us right into pain management, specifically a highly common procedure called radiofrequency ablation, or RFA.
And this is primarily used for chronic neck and back pain, right?
Yeah.
Pain that originates from the facet joints, those small hinges between the vertebrae and the spine.
Exactly. The targets in this procedure are the medial branch nerves. These are tiny, specific nerves whose sole function is to carry pain signals from those arthritic spinal joints up to the brain.
So the logic of RFA is to just intercept the signal.
Right. Under live X-ray guidance, the physician inserts a hollow cannula needle through the thick back muscles until it rests directly adjacent to that medial branch nerve.
Okay, just hearing that makes me wince.
I know. Then, a radiofrequency probe is threaded through the needle. Once activated, the probe is heated to 80 degrees Celsius or 194 degrees Fahrenheit and held there for 60 to 90 seconds.
Wow, so this is not like blowing up a bridge to stop traffic. It's more like dropping a raw egg into a hot frying pan.
That is exactly what it's like. The intense heat instantly scrambles and solidifies the proteins inside the nerve, coagulating it into a solid dead block so it can no longer conduct an electrical pain signal.
So we've successfully burned the nerve. That thermal lesion is supposed to be highly effective at stopping the specific signal from the joint.
It is effective, theoretically. However, the immediate aftermath introduces a severe complication called the flare-up, and this routinely blindsides patients.
Because they undergo the ablation expecting that, with the nerve dead, they'll just wake up pain-free.
Exactly. But instead, 24 to 36 hours later, they are in absolute agony.
The clinical sources describe it as an intense hyperesthesia, which is a heightened extreme sensitivity to touch and temperature. Patients report this deep, burning, throbbing sensation right inside the musculature of their neck or back.
Because the primary nerve may be dead, sure, but the surrounding biological neighborhood is reacting to a 194-degree burn inside the spine. The body registers this as acute massive trauma.
And this triggers the local mast cells.
Right. Mast cells act like microscopic biological alarm bells stationed throughout the tissue. When they're exposed to severe trauma, they burst open or degranulate, flooding the area with inflammatory chemicals.
And looking at the sources, that chemical soup includes histamine, prostaglandins, and bradykinin.
Yes. And histamine doesn't just cause swelling, it actively binds to the surrounding nociceptors.
Those are the neighboring pain receptors that actually survive the burn.
Exactly. When histamine and prostaglandins bind to those receptors, they fundamentally alter the nerve's firing threshold. They lower it to almost zero.
So nerves that normally only fire when you sustain a heavy impact are suddenly triggered by the slightest movement.
Or even just the resting pressure of the surrounding tissue. Normal mechanical pressure is translated by the brain as intense burning pain.
That is wild. And on top of that chemical fire alarm, the post-surgical notes detail the severe physical trauma caused by the tools themselves. The cannula used to guide the radiofrequency probe is a 16 or 18 gauge needle.
Which is huge. That is a thick piece of metal being forcefully punched through muscle layers, fascia, and connective tissue.
Right, and that mechanical tearing disrupts the local architecture of the muscle. Capillaries tear, venules leak blood and interstitial fluid. It creates hidden fluid pockets deep within the muscle planes.
And those pockets exert physical, outward pressure on the surrounding, already chemically sensitized tissues.
So the patient is experiencing this dual-layered hypersensitivity chemical sensitization, lowering the pain threshold, and physical pressure from internal swelling pushing against those raw nerves.
It's a perfect storm. This flare-up peaks between days 2 and 5 and can drag on for weeks.
But wait, hold on. The most surprising detail to me in these clinical sources is that the pain relief from RFA only lasts, on average, 6 to 12 months.
Yeah, that's the kicker.
I thought we just burned the nerve at 194 degrees. Why isn't it permanently dead?
Because peripheral nerves are stubbornly resilient structures. When the radiofrequency probe coagulates the nerve, it doesn't vaporize the entire cellular structure from the spine to the brain. It just disrupts a localized section of the axon.
Okay, so the sources outline a 4-stage biological timeline for this.
Right. Stage 1 is the immediate thermal injury we just discussed. Stage 2, which unfolds over the next 1 to 3 weeks, is called Wallerian degeneration.
This is where the section of the nerve downstream from the burn essentially starves, dies, and breaks apart.
Exactly. The body dispatches Schwann cells and macrophages.
Macrophages are a type of white blood cell, right? Like the immune system's cleanup crew.
Yeah, they physically engulf and digest the dead nerve tissue, clearing away all the biological rubble.
Okay, so once that debris is cleared, the patient enters stage 3, which is signal block and scar formation. The bridge is officially out.
Yep. The electrical signals are completely blocked, and the patient finally gets that profound, intended pain relief.
But it doesn't last, because stage 4 inevitably begins, long-term regeneration.
The nerve stump that survived on the upstream side of the burn slowly starts to grow back. It's attempting to reconnect the severed pathway. Peripheral nerves grow at a rate of approximately 1 millimeter per day.
1 millimeter a day. But this regrowth process is where hypersensitivity can transition from a temporary post-surgical flare-up into a chronic nightmare, because the regrowing nerve doesn't always follow its original neat pathway.
Not at all. The regenerating nerve fibers, the axons, are essentially growing blindly through the tissue, searching for their old connection.
Hmm.
And because the radiofrequency probe created a severe thermal burn, there is often dense scar tissue blocking the route.
So when the regrowing nerve hits that scar tissue, it can't push through.
No. The axons coil back on themselves, growing into a tangled microscopic knot of nerve endings known as a neuroma.
And the sources emphasize that neuromas are notoriously painful because they lack a myelin sheath.
Right. Myelin is the fatty insulating layer that normally coats a nerve, much like the rubber casing on a copper wire.
But because this new tangled knot is uninsulated, it is exquisitely hypersensitive. Like a simple muscle contraction or even shifting your posture in a chair can compress that raw neuroma and fire off intense electrical shock-like pain.
It becomes a hyper-reactive bundle of exposed wiring. And the nervous system has another fascinating, albeit frustrating, adaptation that causes pain to shift unpredictably after these procedures. It's called the recruitment phenomenon.
The recruitment phenomenon. Because the spine is not wired with single isolated cables, right? It's a highly redundant overlapping network of pathways.
Exactly. When the central nervous system realizes that the primary medial branch nerve has been silenced by the ablation, it doesn't just passively accept the loss of sensory input from that spinal joint.
The brain actively seeks out alternative routes.
Nice. Neighboring collateral nerves that previously only handled a tiny fraction of the sensory load will biologically upregulate. They expand their receptive fields, stretching their territory to cover the silenced zone.
So patients frequently return to their doctor confused, reporting that their original deep joint pain is gone, but they now have a strange new burning pain slightly to the left or radiating down their shoulder.
And the doctor knows it isn't a psychological manifestation. Those neighboring nerves have literally turned up their own sensory volume, becoming artificially hypersensitive to fill the informational void left by the burned nerve.
The pain wasn't eliminated. The nervous system simply forced the signal through a different, newly sensitized channel.
Exactly.
So bringing this all together, whether we analyze a cosmetic laser targeting hair follicles on the surface or a radiofrequency device attempting to force fibroblasts to remodel mucosal tissue, or a 194-degree probe intentionally coagulating a nerve root deep in the spine,
Yeah.
all of these energy devices operate on the fundamental principle of thermal injury.
Heat. Yes.
Yeah.
And the hypersensitivity that follows, whether it's the mild expected tingle of superficial skin inflammation, the chronic hypertonus and scarring of mucosal burns, or the severe electrical shock of a tangled neuroma, is almost always the body's natural, inflammatory, and incredibly determined biological response to that injury.
It's like the expectation of engineering precision simply does not survive contact with the muddy, resilient reality of human physiology.
It really forces us to consider the sheer stubbornness of our own nervous system. I mean, think about it. We invent these highly advanced computerized lasers and probes to silence the body's alarms or to force it to remodel itself to our exact aesthetic or medical liking. But your nervous system is so desperately committed to keeping you informed about your environment that if you burn its primary communication line, it refuses to stay quiet.
It'll trigger mast cells to flood the area with histamine.
It will reroute the signal, it will recruit neighboring nerves to shout louder, or it will grow entirely new raw pathways just to ensure its message is received. It begs the question, are we truly mastering our nervous system with these energy technologies, or are we just forcing it to learn a new, more painful language?
Wow. That is definitely something to think about the next time you see an ad for a quick laser-based fix. Thank you so much for joining us on this deep dive. Keep questioning the science and the mechanisms behind the everyday treatments around you, and we'll see you next time.